Assalamu alaikum. Welcome everyone on board. Yesterday I couldn't take the class, so we will continue from where we stopped yesterday, day before yesterday. So the first discussion MCQ is a 56-year-old man who is in ICU following laparotomy. Okay, so you just think that what can be the reasons of bowel obstruction in this age group. Okay, um, uh, there are a number of things will come in the differential diagnosis. He is hypertensive, has a high BMI. Okay, so this is class 3 obesity and had ileus. So just rethink what may be the causes of ileus. Uh, his abdomen is tender and tensely distended. There are no signs of sepsis, but he has worsening renal function and a poor urine output despite a very positive fluid balance. So this picture is towards abdominal compartment syndrome. Okay, so he had become increasingly breathless with type 2 respiratory failure. And after a failed trial of non-invasive ventilation, is now mechanically ventilated. His ventilator pressures are worsening, and his base excess and lactate are increasing. So this is a sign of a collapsed patient with most probably there is element of sepsis, and because lactate is also telling about anaerobic metabolism. Okay, base excess is worsening, patient is having metabolic acidosis. So what is the measurement of intra-abdominal pressure is most safely performed with an intraperitoneal catheter and pressure transducer. It's not a very safe thing. An intravesical measurement is performed at the end of inspiration. At the end of inspiration or at expiration. Let's see. Abdominal compartment syndrome may provoke a cardiac arrest at laparotomy. Uh, an abdominal pressure of 24 millimeter mercury can be considered normal. The only effective treatment is real laparotomy, leaving the abdomen open with a Baguta bag. Let's see the answer. Uh, so abdominal compartment syndrome may provoke a cardiac arrest at laparotomy. This is the correct answer. Let's see how this is, because the question is revolving around abdominal compartment syndrome. So actually, abdominal compartment syndrome is raised in abdominal pressure with development of a new organ failure. Okay, so the management of abdominal hypertension and compartment syndrome can be imagined in a similar way to elevated intracranial pressure. Okay, thus the initial management relies on the maintenance of abdominal perfusion pressure, which is mean arterial pressure minus intra-abdominal pressure. So we target more than 60 millimeter of mercury shown to improve an outcome. So intra-abdominal pressure is in the range of 5 to 7. Even during normal coughing or sneezing, intra-abdominal pressure transiently can increase. Okay, but of course it will not remain for a very long time. Uh, okay, and this is increased by abdominal fluid or collection, upright position, and mechanical ventilation. Intra-abdominal hypertension is diagnosed with a pressure persisting above 12 millimeter and is termed compartment syndrome when the pressure is consistently above 20 millimeter mercury with new organ failure. So this is the definition of abdominal compartment syndrome. Okay, so normally 5 to 7 may reach up to 12 millimeter mercury. We will say hypertension, and if the new organ failure occur, we will consider it as abdominal compartment syndrome. Measurement can be direct using an intramedullary needle or catheter or transducer system, or indirectly via intravesical, intragastric, intrauterine, or rectal route. The commonest route is bladder, which can make use of a normal fully catheter and gives reliable result with low risk than direct method, because intraperitoneal method is not safe. And the process involves connecting a transducer to a three-way tap, which measures the pressure of 25 ml sterile saline instilled to an empty bladder. After the catheter is clamped, reading should be taken at end expiration, not end inspiration. Okay. Though in the option they were saying end inspiration. And 1 minute following installation of a saline to allow for bladder relaxation. The patient should have a relaxed abdominal wall and not be coughing, straining. Because if inspiration, it will be not be relaxed. So systemic pathological effects of increased abdominal pressure has wide ranging systemic effects. High abdominal pressure produces collapse of the vasculature. On the venous side, then gives to rise to reduction in venous return and reduced stroke volume. Not only it will collapse the vasculature going towards the like abdominal viscera, it will increase the pressure and there will be decrease venous return. And then this blood pressure automatically will decrease, stroke volume will decrease, cardiac output will decrease. Arterial compression gives an increase SVR and afterload. Okay, the combined effect are those of reduced cardiac output that can rapidly spiral to reduce gut ischemia. So whenever there is gut ischemia, lactate will go up. Okay. Respiratory features are those of respiratory failure due to atelectasis, collapse because the diaphragm will pushed up, so there will be decreased in the compliance, and all the pressures will raise and volumes will come. So there is atelectasis, collapse, and then there will be shunting. So there is a reduction in chest wall compliance and diaphragmatic excursion. In ventilated patient, the increased pressure required to maintain oxygenation and ventilation can compromise cardiac output. Okay, so it will have effect on the cardiac output as well. Renal function is impaired as combined result of reduced cardiac output and a GFR and a decreased GFR. Decrease filtration gradient. The filtration gradient is the pressure difference across the glomerulus, and it is therefore difference between the perfusion pressure and pressure in the proximal tubule. Raised intra-abdominal pressure compresses the collapsible renal outflow tracts and collecting system such that the tubular pressure rises, so the filtration pressure will decrease and GFR will decrease. Then thereby lowering fraction gradient. So this filtration gradient, that is what is mentioned here. Okay, so because there is venous pressure, so it is directed towards vasculature of renal vasculature. Okay, and so the filtration gradient will decrease, so reduces both the abdominal perfusion pressure and raises the tubular pressure, all of which reduces the filtration gradient required to drive filtration. They are just explaining how the renal function is distorted in increased intra-abdominal pressure. High AP also increase ICP. This occurs by a combination of high intrathoracic pressure and reduced venous return and ventilatory difficulties and the consequences of high CO2. Okay, so combination of high CO2 will directly increase the ICP. Abdominal compartment pressure is particularly dangerous and may mandate surgical abdominal decompression to lower ICP. Okay. Non-surgical management is directed towards the joint aims of lowering intra-abdominal pressure and maintaining abdominal perfusion pressure with careful fluid resuscitation to normal volemia, followed by vasopressor support if required. Over-enthusiastic fluid therapy will cause gut edema. So that's a very important point. And further compromise tissue perfusion. So goal-directed fluid therapy. Pressure in the abdomen may be lowered by reducing the volume of content okay, with NG. So NG deflation, endoscopic evacuation of or invasive drainage of gas or fluid. In addition, the ventilated patient consideration can be given to optimal sedation and muscle relaxation because it will also increase the abdominal pressure. Okay, surgical management involves laparotomy and decompression. The usually now a number of times they are also doing laparoscopic view followed by laparotomy if needed. A number of times they do like this as well. Abdomen is thus left open and covered with a temporary closure of Baguta bag or vacuum dressing. It remains important to measure abdominal pressure even after decompression, as A 25% of patients with Bogota bag go on to develop secondary hypertension. The serious caution should be exercised at laparotomy for raised intra-abdominal pressure, as profound hemodynamic instability may ensue as a consequence of abdominal reperfusion alongside a sudden fall in SVR. This can be massive and of sufficient magnitude to bring about cardiac arrest. So this is what they are saying. Serious caution should be exercised at laparotomy for raised IAP as profound hemodynamic stability. When they are deflating, suddenly patient can have cardiac arrest. So that was the point which they were highlighting. Indirect methods of measurement reduce the risk of complication associated with needle or catheter techniques. Measurement takes place at the end of expiration. The pressure of 24 mercury is more than double the cut half for hypertension at the range of compartment syndrome. If sustained management strategies are described above, with non-surgical options also available. Laparotomy is needed at risk, is indeed a risk factor for cardiac arrest, given the massive physiological change that occurs in this situation. That's why when we are managing, so actually in this one MCQ, they have told you almost all the important points with reference to laparotomy actually. So you can see that a number of time patient collapse when they deflate. So that's a very critical step. So they have even given the reference of this CESACP article. I will just show you right here. It's a very nice compartment syndrome. So this was the article through which they giving the reference. This is how they are measuring. Okay, so intra-abdominal pressure and abdominal perfusion pressure. So, so these are the effects of intra-abdominal hypertension. Raised ICP, SVR increase, pulmonary vascular resistance increase, decrease venous return, and then cardiac output, increase VQ mismatch. Okay, decrease chest wall compliance, high PaCO2, PO2 also decrease, increase renal tubular pressure and urinary obstruction, decrease renal blood flow and urine output. So you can just have a look here. This was about which we were discussing about decrease filtration gradient. Okay, so this is a topic which is frequently asked in oral exam as well. So you can see right here. Okay. Oof. Sorry, it closed suddenly. Okay, so this question is on actually flow volume loop. A 60-year-old man waiting surgical resection of for his tracheal carcinoma presents to the emergency department with worsening dyspnea. As part of his pulmonary function test, a bedside flow meter is ordered. What will be the most likely appearance of his flow volume loop? I think it is the one which both sides are decreased, if I'm not wrong. And the tracheal carcinoma, just let's see. Um, okay. A flow volume loop is a plot of flow rate against lung volume during maximal force inspiration and expiration. Okay. The contour of this loop can aid in localizing upper airway obstruction and assessing their functional impact. Upper airway obstructions are classified as either intrathoracic or extrathoracic. This is for upper airway, depending on whether they are present within or outside the thoracic inlet. Uh, in if it is within thoracic inlet, it will be intrathoracic, and if it is outside, so it is extrathoracic. In addition, they are also described as variable or fixed, depending on whether the airway lesion caliber changes during respiratory cycle. Okay, so for variable extrathoracic obstructions such as vocal cord paralysis, the inspiratory portion will be flattened. I will show you the graphs for it. And this is because during inspiration, the transmural pressure is negative as a result of subatmospheric intraluminal pressure and atmospheric extraluminal pressure. Again, I will repeat just a second. Actually, this is a difficult topic. It's written very nicely here. I will show you. For physiology, if you whatever topics and not every topic is written here, but whatever topics are written here, they are written very nicely. So I will highly recommend you, whenever possible, have a look here. You will find here. Actually, in this is the normal. So this is the area which is there, and even when the volume of air which is remaining in the lungs, that is residual volume. So from here, the flow rate is this occurs with the inspiration. Okay, so flow is in negative, and then when it comes out, so it is just like for expiration. So it occurs like this. Okay, so note that the highest volume is on the left of the x-axis. So this is x-axis, this is y-axis. The volume, the units on the y-axis are liter per second as opposed to liter per minute. So positive reflection occurs during expiration, like what is happening here. Okay, because when the flow is coming out, that is coming as a positive deflection during expiration, and negative deflection occurs during inspiration. So this is showing in the minus. So this is in positive, and this is in negative. Okay, so so when the patient takes a vital capacity breath before starting the test with a force expiration. So here, like if the patient is taking the full volume, it reach up to total lung capacity. So this is the residual volume after expiration. uh, like when the expiration occurs, the flow is coming maximum, and then gradually uh, when we pull out all air from our mouth. So still the zero balance will come, residual volume will still be there. So this part, just a second, this part which is shown here is like this part which is this part which is from here to here, from this arrow to this area is residual volume. Okay, so this is how it is. Initially patient is taking full vital capacity breath. So the volume of air which is inside the lungs at the end of inspiration is the total lung capacity. So you can say here, right here. So this is the concept. Then when the patient start expiring, it is going to the maximum and then gradually decrease, and maximum when it is reaching here. So that's the normal loop. So let's read here. The patient takes a vital capacity breath before starting the test with a forced expiration. The loop is drawn in a clockwise direction, starting from TLC. So it is total lung capacity is a volume when we take a full breath inside. So that is total lung capacity. And when we pull out, so maximum which we can expire is like forced vital capacity. Okay. So it is a volume of air which can be expired after full vital capacity breath. That is the concept. Full inspiratory effort. So that is the force vital capacity. And force vital capacity does not include the residual volume. Okay. So the loop is drawn in a clockwise as it is mentioned from here. Uh, the flow rate decreases steadily at expiration, continues in a left to right direction, from left to right, from this direction to this direction. The flow rate then decreases steadily at expiration, continues to in the left to right direction, so that a relatively straight curve is produced with a slightly concavity at its center. That's what is shown here in this part. In this part, in the middle, at this arrow is here. So this is concavity like this. Uh, An important point to demonstrate is the phenomenon of dynamic compression of airways. The curve traced by the normal loop represent the maximum possible flow rate at each lung volume. Okay, even like they are showing at they are showing the flow and volume, the relationship between the flow and volume. Whatever volume is there in the lungs, and whatever flow will be during the inspiration or expiration. So it is making a relationship between flow and volume, the volume of the air in the lungs with reference to the flow. Okay, so at the end of at the end that's at the start of expiration you can see the maximum flow, and at the end of expiration you will find the minimum flow. That's how it is the concept of this graph. Okay. Uh, the curve traced by the okay, even if the patient holds back their maximum effort by expiring slowly at first B, what is showing here, they will be unable to cross this maximum float line. This is because the airways are compressed by a rise in intrathoracic pressure, thus limiting flow. The more effort that is put into expiration, the more these airways are compressed, and so total flow remains the same. The inspiratory limb has a sharper, much squarer shape, and a maximum flow of 4 to 6 liters per second is also achieved. Inspiration occurs from residual volume to total lung capacity. Okay, gradually we fill up, and when maximum it goes from this place. So this place to this place is the inspiration. Okay, so now what occurs in the I will show you the graph for this disease, the fix one, this one first here, when there is fixed obstruction. So this curve is seen where a large airway has a fixed orifice through which gas is able to flow, such as may be seen in patient with tracheal stenosis. The peak inspirate the peak inspiratory and expiratory flow rates are therefore dependent on the diameter of the orifice rather than the effort. The curve should be drawn almost symmetrical as above, with both limbs demonstrating marked reduced flow. The TLC and residual volume are unaffected. In this one, the fix as shown here in this MCQ is this one. So the other one, in the variable extrathoracic obstruction, you can see that inspiratory is decrease. Okay, so an extrathoracic obstruction is more likely to allow gas during its expiration. Okay, as the positive pressure generated during this phase acts to force the air or airway open. As such, the expiratory limb may be near normal as occur in this case. Okay, so extrathoracic will affect inspiratory limb, and intrathoracic will affect the expiratory limb. In contrast, the negative pressure generated in the airway during inspiration serves to, because when negative pressure it sucks in and it closes. So during inspiration serves to collapse the airway further, and the inspiratory limb will show markedly reduced flow rates at all volumes while retaining its square shape. Both the total lung capacity and residual volume are in fact unaffected. Okay, and this is the variable intrathoracic. When intrathoracic, what will happen? The expiratory limb will be disturbed. Okay, and intrathoracic obstruction is more likely to allow gas flow during inspiration, as the negative intrathoracic pressure generated helps to pull the airways open. As such, the inspiratory limb of the curve may be near normal. Okay. In contrast, the positive pressure generated during forced expiration serves only to exacerbate the obstruction. As such, the expiratory limb appears normal, similar to that seen in the obstructive disease. So the, both TLC and residual volume are generally unaffected. So what will happen in obstructive disease? This will also, but here the residual volume will increase, as we will show here. Now I will show you the in the obstruction what happens. You can see, just have a look here. The residual volume is like this, and here you will see in obstruction that you see residual volume is increased. So this portion which was here becomes here, because now the more air patient is unable to expire. So there is problem in the expiratory limb, and the residual volume is increased. So the volume, total lung capacity actually may be increased, but you can say obstructive disease reduces peak expiratory flow rate and increase the residual volume via gas trapping. So that is a concept which we can just think about in the obstructive disease when their air trapping occurs. The total lung capacity may also be higher, although this is difficult to demonstrate without values on the x-axis. The important, the x-axis is this one. So they are not showing here; they are just showing the flow. So more important point to demonstrate is reduced flow rates during all of expiration. You see, all of expiration with increased concavity of the expiratory limb owing to the airway obstruction. So this is how it appears. So in intrathoracic obstruction, this occurs also, but the residual volume is not changed. So if you want to identify in the when it comes in the OSCE or in the oral part, or even in if they show you in the MCQ, they can show you the graph and they can ask which type it is. So you can identify with the residual volume. Okay. So this is how it occurs. So okay, so the inspiratory limb is less affected and can be drawn as for normal. Now the restrictive disease. In restrictive disease, one happen, you can say the residual volume is the same, but total lung capacity is markedly decreased. So you can see they have pushed the graph on this side because this is restrictive lung disease. So the total lung capacity is decreased. In contrast to obstructive disease, the restrictive lung disease markedly reduces TLC. So you can say that instead of total lung capacity to be here, it's shifted to on the right. Okay. That is similar in shape to the normal curve, but in which the flow rates are reduced. In addition, the left hand side of the curve is shifted to the right. So you can see that and demonstrate these points curving that is similar to shape in normal. The curve is normal, but is small. Okay. So that's how you can so we discussed the fixed, the restrictive, the obstructive, the variable intrathoracic and variable extrathoracic. So this is a very important point. So you can see the role of residual volume, the total lung capacity, and how this is, remember one thing I am again repeating, this is the change in flow with reference to different volumes of the lung. Okay. So this is what is flow volume loop. So the question which was asked here was on this basis that there is tracheal CA. So it's like a tracheal stenosis. So it's a you can say flattening of both the inspiratory and expiratory limb as we discussed. Okay. For variable, we will discuss about it. Fixed airway obstruction are characterized by the constant degree of airflow limitation during the whole respiratory cycle, as they limit the influence on the uh, transmural pressures on airway diameter. They can be extrathoracic or intrathoracic. and their flow loops display flattening of both inspiratory and expiratory limbs. The above case is example of a fixed airway obstruction. Okay. What about sawtooth? Tooth pattern describes small oscillations which can be observed throughout the inspiratory expiratory limbs of the flow volume loops as a consequence of either equipment artifact or neuromuscular disease or pedunculated tumors. Uh, So, low volume loop in the presence of a variable intrathoracic obstruction such as bronchogenic cyst classically displays a flattened expiratory and normal inspiratory. Okay. So intrathoracic obstruction, the flattened expiratory, as we discussed just now. Flow limitation is encountered during expiration because it at this phase of the respiratory cycle, the pleural pressure exceeds the airway pressures, exacerbating the obstruction. It's a very difficult and boring topic actually. I have just tried to explain as much as I can. Okay. A 32-year-old woman was recently diagnosed with brainstem death following a subarachnoid hemorrhage. She was initially hypertensive, then developed polyuria and gradually became hypotensive. The patient received 30 ml per kg of fluid bolus. The next, actually, this topic is on the basis of the patient for brainstem death for organ donation. Okay. So in this case, actually, we have to maintain the blood pressure. We have to maintain the vasopressin is required at T3, T4. So thyroxine may be required. Steroids are required. So that is, I think, in this to maintain the blood pressure. After fluid is to give the answer actually is vasopressin because just a second, we will see here. Brainstem herniation cause relative hypotension and bradycardia after an initial period of hypertension due to catecholamine release. This is due to loss of autonomic control of vasomotor tone and loss of vagal tone. This is due to loss of autonomic control of vasomotor tone and loss of both sympathetic and parasympathetic tone. Treating episodes of hypotension with adrenergic vasoactive drugs exacerbate end organ ischemia, and they are contraindicated in a potential organ donor. Vasopressin is the agent of choice to treat hypotension and maintain vascular tone following brainstem herniation as it improves organ perfusion and corrects the polyuric component of the diabetes insipidus because it has both effects uh, caused by hypothalamic ischemia. Fluid boluses are useful to maintain euvolemia, but overfilling patients also risk detrimental outcomes to organs. So uh, this I will show you here. Actually, this is how one MCQ can give cover one topic for you. So whenever you read MCQ, try to explore your brain, and you have to cover the sideway things. Okay. So I think this is the so this is the topic. I think this is the article about which I was discussing. Just- Mm, there was a chart in which it is written that what medication need to be given. I just wanted to show you that chart. Yes, you see. So that is the medication which we need to give when we are uh, keeping a patient for. Uh, organ donation. So insulin, steroid, T3, vasopressin, and desmopressin. These are the medications which we need to give the to have the targets written here, I think. Yes. So these are the goals which we need to fulfill with reference to mean arterial pressure, CVP, heart rate, and then PF ratio, uh, the urine output, the metabolic goals with the maintenance of pH, sodium balance, endocrine, and temperature. So these are the things because this question they can ask you in the oral part as well as the MCQs can come. So let's do one more question. You have asked to see a 32-year-old patient in recovery following a retrograde intramedullary femoral nailing. So you can just think about all the complications which can occur in a femur fracture with like if they have put a bone cement, so bone cement syndrome can occur, fat embolism, thromboembolism, the problems with reference to pain, okay, and the problem in positioning the patient for regional anesthesia, GA versus regional anesthesia for this case, any other coexist is in the like in case of trauma you have always have to rule out other trauma, so these are the things which should be in your mind. And he works as a builder and fell from a ladder sustaining bilateral femur fracture. The plan is to fix the other leg in the next few days. He is desaturating to 88% on oxygen by a face mask and is confused. And one of the recovery staff has also noted particular rash on the patient's neck. So this picture is towards the uh, this fat embolism. So let's see in the diagnosis and treatment of the likely condition, which of the following tests is most important? ABG, bronchoalveolar lavage for macrophages, trial of methylprednisolone, CT of the chest, urine microscopy for lipid droplet. I think it should be the answer. Let's see which is the answer. ABGs. Fat embolism indicates the presence of fat within the pulmonary or the peripheral circulation, often without symptoms. Fat embolism syndrome is the clinical consequence of fat embolism occurring in some patients and has a quoted mortality 5 to 15. The commonest impacted fractures are those closed fractures of long bones. The greater number of fractures, the higher the incidence. A third of patients with bilateral femur fracture goes on to develop the syndrome. The presentation is within 1 to 3 days. It's like subacute because air embolism and this thromboembolism is relatively acute. Fat embolism and amniotic fluid embolism is a little relatively subacute. There are a variety of sets of published diagnostic criteria, but all have in common either ABGs or clinical features of profound type 1 respiratory failure. Clinically, the two major tenets are neurological dysfunction, most commonly acute confusion, and the classical petechial rash. Rash may be a late sign and only present in 60% of cases. Blood indices most often reflect a marked anemia with thrombocytopenia. Other features such as fat and sputum, urine, and alveolar macrophages may support the diagnosis, but equally do not correlate well with the severity of the syndrome. Pathophysiology with mechanical theory or immunological theory. Okay, so the mechanical theory, physical disruption forces adipose marrow into the venous system, and bones with high marrow content are indeed most associated with the syndrome. However, studies have directly demonstrated embolic load in patients during orthopedic surgery who have not progressed to develop the clinical syndrome. That is another point. The mechanical theory also does not explain why, despite the fact that embolism is greatest around the time of the injury, occurrence of the syndrome peaks at 24 to 72 hours. So this shows the involvement of immunological system. The biochemical theory ascribes toxicity to the hydrolytic degradation of neutral bone marrow fat to free fatty acids. These free acids are shown to be able to induce acute lung injury. C-reactive proteins may also have a role in abnormal lipid metabolism. in these patients. So this is the immunological theory or biochemical theory. The treatment essentially is supportive with good oxygenation and ventilation in ICU environment if indicated. Correction of blood indices may be needed. Prevention is with the operative fixation after early immobilization, and some operative technique exists to reduce intraosseous pressure during drilling and reaming to reduce the embolic load. Some advocate steroid prophylaxis with methylprednisolone for these patients at high risk with some evidence to support this. There is no evidence to support the use of steroids as a treatment, however. Aspirin may speed recovery of platelets and possible lung injury. In this question, the STEM highlights the diagnosis of fat embolism syndrome, which most customers are likely to discern. The real question relates to the most helpful test in both diagnosis and treatment, which requires more extensive understanding of the disease. Special investigation which have been used to assess the diagnosis, bronchoalveolar lavage for lipid-laden macrophages, and urine microscopy for lipid, but may not add much over clinical examination particularly. Given the patient presents with telltale critical rash, CT and chest X-ray findings may be variable, and unlike in prevention, there is no beneficial role of steroid. ABG will, however, both assist in diagnosis. PA2 is in all diagnostic criteria and help the clinician decide on the level of respiratory support required. So we will just reread. Uh, you see the thing which I missed, and I think I'm not sure about that. Because diagnosis and treatment. Urine microscopy will not lead in treatment. Okay. So that is why the best answer is ABGs. That because it will not only guide the diagnosis, also treatment. Okay. So that was the catch in this question because they are that's why remember one thing. These 5 lines are data. In this one, you will find the data, but the most important thing is what they are asking because the thing which they are asking will change the option. So actually, all these things are done. Methylprednisolone maybe have some prevention, but not clearly. Bronchoalveolar lavage will also aid diagnosis, but not treatment. Urine microscopy will also aid diagnosis, but not treatment. ABGs is the one which will be telling the both. Okay. So uh, again, as I show you, this is the article for fat embolism. And you will see the people who are preparing for the exam, you will find uh, the reference also a number of times they are taking from these articles. So this was the diagnostic criteria. We will just finish here. So this is a major criteria with axillary or subconjunctival petechiae hypoxemia, CNS depression disproportionate to hypoxemia, the confusion, pulmonary edema, and minor criteria is tachycardia, hyper hyperthermia, emboli present in the retina, fat in the urine, okay, sudden drop in hematocrit or platelet values, increasing ESR, fat globules in the sputum. So you can read, you can have a look on this topic. So thank you very much. So uh, okay, bye bye.